size of the alveolus gets smaller, then they get a chance to get closer to each other again. And then there goes that really strong attraction. And they're pulling toward each other. So in the midst of that, they're making it hard for the alveolus to re-expand again. Now, when you add surfactant, what they did here was they just made it like little, you can look at it as almost like little springs, I guess, between the water molecules. And what would happen is no matter what, because of those springs between the water molecules, they're never going to really have a chance to get close to each other. And that would make it a whole lot easier, as we see here, to get this alveolus to re-expand again or to reinflate. Because as you see, the distance between them is pretty much still the same. So really what's happening is the surfactant, as we know, there's a hydrophobic end and there's a hydrophilic end. And the hydrophilic ends are going to, let's see, what can we do? This would be, say, the alveolar surface here. Or so we're going to look at the inside. And then there's a layer of water. I'm just going to represent the water as like wavy. And then for the surfactant, let's do this. So of course, with the surfactant, the hydrophobic end is going to be attracted to the water. Hydrophilic, did I say phobic? And of course, the hydrophobic ends are not. Or the hydrophobic tails. Now, the charge on these hydrophilic ends are usually positive, which means these are always going to be repelling each other. And that means that also the water molecules are going to be pushed apart as well. So that's why they just represented the actual surfactant as just like these little springs that are just going to ensure that these water molecules don't really come close to each other anymore. So again, it's all made possible because of the charges of the hydrophobic or hydrophilic ends of the surfactant molecules. So I'm just going to write positive charge as repel. And this is positive, that's positive, this is positive. And again, I didn't want to actually write the water molecules per se, and we know it's just two hydrogens and one oxygen bonded together, but that's what's all in the water layer. So now, carbon dioxide and water. When you exhale out your CO2, then of course you're also exhaling out water vapor. So your alveoli are always going to have this layer of liquid. So they call it like the air-liquid interface when you look at the air on the inside of the alveolus versus the thin layer of water that's on the surface of the alveolus. And that's always going to be a source of surface tension. If you didn't have enough surfactant, or if you didn't have any surfactant at all, it would be nearly impossible to get your alveoli to expand again, or at least to open like they're supposed to. Alveoli are going to be different sizes. I mean, they're all microscopic, but still, some of them are just naturally going to be much smaller than others, especially depending on where they are. Alveoli in the upper lobes are usually going to be a little bit larger. There's more negative pressure in the apical segments versus in the lower lobes where the alveoli tend to be a little bit smaller. So without any surfactant, it would be trouble for us. And as it says here, think about the baby who was just born, all that fetal lung fluid that had been in the lungs all that time. And now that they're trying to clear away all this fluid, to get the alveoli to open up, it could take almost 80 to 90 centimeters of water pressure to open up the lungs. Now, for NRP purposes, they want you to remember that the very first breath that you have to give a newborn who's not breathing, it may require about 30 to 40 of pressure to get them to open up. But here's just saying, like, just really theoretically, it could be double that in some cases to try to get those alveoli to get, so the water molecules are going to be separated from each other. So of course, immature surfactant is going to be a huge problem for a newborn. But with adequate surfactant, or with mature surfactant, or with surfactant that we give as therapy, as a therapeutic intervention, that's what's going to make the difference between, say, a newborn who will get sicker and end up in really bad RDS versus a newborn who will start to show some progress, usually like in a few days, like in a day or two. So really nothing new here. We know that the type 2 cells are going to be responsible for secreting the surfactant. The type 2 cuboidal type cells versus the type 1, which are like the simple squamous cells that are there to essentially create the alveolar walls. Now, metabolism, of course, there's going to be different reasons why surfactant is produced and at whatever particular time it needs to be produced. So like in the case of stretch, anytime that the lungs are stretching, then that should mean that surfactant will move into the lungs, into the lung space, and coat the surface of the alveolus, so that way it can interfere with this surface tension between these water molecules. And then when it's no longer needed, it's just reabsorbed back into the system. So they're saying into the tubular myelin, or it's transformed into tubular myelin. So really what happens is, we know that there's like a constant production of surfactant, and then there has to be some kind of reabsorption or recycling that happens. So that way we don't end up flooding our lungs with too much surfactant. And 90%, well, pretty much all of it is going to be just reabsorbed back into those type 2 cells. So they'll secrete it, and then they'll just reabsorb it as they need to. Now, when you look at what surfactant really is, it again with that hydrophobic end and the hydrophilic tail portions, most of it is just going to be fats. It's just like 90% lipids, and then about 10% is going to be the proteins. Now, as far as the PC, the phosphatidylcholine, that is going to be the majority of what surfactant is made up of. Now, when we look at the proteins, so that 10% composition is really A, B, C, and D type proteins that are being generated. And then we just make the distinction here that we need to have those A and D proteins for sure to make sure that the hydrophilic ends of the molecule are hydrophilic. And the B and the C are going to be the hydrophobic components. And then notice that also your SPD is going to have a role in immunity as well. So it's going to almost help like with the like the T cells and take care of like any organism or any kind of foreign bodies that don't need to be there. Now, here's a situation where you've got a preemie who may have to be born like really, really early. So let's say you've got a preemie who is about 28 weeks. And we know that at 28 weeks, the surfactant is not really matured yet. It's not completely matured. So if there's nothing that they can do to prevent the delivery from happening, despite using all of the methods that they try to use to slow things down and literally to stop labor, then what they could do is they can give the steroids to mom. And once the steroids cross over the placenta into the baby's system, then that's what's going to help to speed up the maturation process of the surfactant. And then there's a note here that they may recommend thyroid hormone therapy, but most of the thyroid, as you see, is not really going to be able to cross over the placenta. Things that cross over the placenta are usually like fats and amino acids and sugar, things of that nature. But certain hormones are just not going to be able just to simply pass over or actually be transported over. And in this picture right here is just kind of like an overview of all the different things that steroids can do for the body. I mean, it's just like some of the more common things that the steroids can do. And this is all in the name of trying to get that surfactant to be prepared so that if the baby does have to be born this early, then there would be a better outcome. Now, we know when it comes to the LS ratio test, it's all about that ratio of 2 to 1. Phosphatidylcholine versus the sphingomyelin. Now, if you wanted to really, because this LS ratio can sometimes be a little bit misleading, and it may not be a really good marker for predicting the surfactant maturity. So a lot of times what they'll do is they'll just focus on just looking at how much of the phosphatidylglycerol, look at those levels instead of looking at the actual LS ratio itself. But even still, that would be kind of considered the standard in most places, is just to check that LS ratio to see if you've got more than a 2 to 1 ratio. Now, this section here talks about the different things that can happen, like when there's an acute lung injury, as far as how it's going to affect your surfactant, either the surfactant production or just the surfactant, the ability for it to to work like it's supposed to work. So this part of the chapter, there's a lot of this study, this study, that, and this is what we found here, and this is what we found there. But really, when we just kind of sum it all up and we look at it as far as, like, for example, ARDS. ARDS is kind of like one of those cases where you would be thinking that we really need to consider giving maybe some surfactant therapy because the lung compliance is so poor and oxygenation is so bad that it stands to reason that we should probably be thinking this is a classic situation that's going to require surfactant. But this is mostly just to kind of show that if you didn't want to consider giving surfactant therapy, then just know that because of this process of ARDS and what's happening at the alveolar level, at the capillaries, and just in general at the organ level, when you think about the lungs, then your surfactant is really not going to work like it's supposed to. It's literally being destroyed by this whole process that's involved with ARDS. And ARDS is going to be one of our topics in that last course that comes around in about a week or two. So again, we'll come right back to this and just kind of look at that whole process in just a little bit more detail. And then the second bullet point was, again, definitely one of the studies that they were talking about where they found that giving a patient 85% of O2 kind of benefited and meant that there was a little bit more surfactant being produced. But then in the other subjects, when they were given, say, like 100% O2, then that pretty much destroyed the surfactant. And then your acute lung injuries or ALIs, it's pretty much the same as like any kind of lung injury, like ARDS or just an ALI in general. You would expect that your surfactant it'll be negatively affected. So not only is the overall, the chemical structure is now going to be not correct, which means your overall composition is not going to be right. And then the actual pathways aren't there like they're supposed to, like as far as like the metabolism, and then it's just not going to be effective. If you are producing surfactant in an acute lung injury, it's just not going to really help. And one of the main reasons why your surfactant is ineffective, as they say here, is because of those proteins, like those ABCD proteins they're not working. And you know, when a protein becomes denatured, if it starts to end up folding in a different way than it's supposed to fold on itself, it's going to change everything. So the overall protein itself is going to be, and I wouldn't want to say mutated. I don't want to use the word mutation, but it's just definitely going to be inactive. Now, this chart here just kind of shows no matter which direction you choose to go first, you're always going to end up with the same problem. So I'm just going to go straight down the list here, starting on the right side here. So you've got an acute lung injury, which means that there's going to be lots of swelling and inflammation. And then that's going to ultimately affect your SPA proteins, the hydrophilic ones. And then that's going to kind of like snowball. So inflammation brings more inflammation because of all these mediators that are going to be released when there is inflammation. So then you've got more inflammation on top of more inflammation. And then overall, your surfactant is just not going to work anymore if you are producing surfactant. And then because of the surfactant not working properly, what we expect to happen as far as the pulmonary mechanics and oxygenation, you're going to have a hard time getting your alveoli to inflate. So that's our decreased FRC. And because of the alveoli not really wanting to inflate, that would mean that you're going to have really bad lung compliance. If you can get them to inflate, it's going to require a lot of pressure. So changing volume over changing pressure is what we're talking about here with compliance. So if you do manage to get them to inflate, it's going to require a lot of pressure. And then because you've got the problems with lung inflation, then that will mean that gas exchange is going to be affected, which means that your shunt fractions are going to start going up. So we're looking at extreme cases of refractory hypoxemia. And again, it just no matter which pathway you take on this chart here, you're going to end up with the same end result. Now, what can we do for that newborn who we know has not had a chance to produce surfactant or hadn't had a chance to produce mature surfactant? So they usually will end up in RDS, or respiratory distress syndrome. And they're saying here, a lot of times less than 35 weekers are going to be affected. But that's why they use the word mainly, because this is not absolute. I mean, you could have some preemies who are a little bit older than 35 weeks and still end up in RDS. But what they do know is that the smaller the baby, the greater the chances of them developing RDS. So we're talking like our VLBWs and ELBWs. They for sure are probably going to develop RDS. Now, when we start to plan our replacement therapy, or our surfactant replacement therapy, we have to decide what type or what source do we want to use. Now, they all work the same way, more or less, but it really comes down to how that manufacturer has designed that product and how much are you going to need to give. Because say like in the case of surfactant, just plain old surfactant, which is usually, as you see, you get it from either cows or pigs, and in some case rabbits. Surfactant will usually require a lot. And because it requires a lot to administer, it may not all absorb. So back to our micro preemie, who's only so big. And then you do your calculations for how much surfactant you need to give. And it ends up being almost as much as the baby weighs. And I'm being a little bit extreme, but just to try to like illustrate the point that surfactant will not always be completely absorbed into the lungs when you instill it into the lungs. Sometimes it will, sometimes it won't. But then you have other manufacturers who will come up with, like, say, ExoSurf or CuraSurf or Newfactant or whatever, and then they will market it by saying only have to give like half of the amount that you normally would give, or maybe a quarter of the amount you would normally give, and it would still be effective. And then I forgot this last point. They've been pretty much using amniotic fluid to generate surfactant, which we know would probably be a whole lot better when you think about the genetics. I mean, the amniotic fluid, the baby's genes are still in that fluid, or the baby's genes are in that fluid. So we're talking about using a human source versus, say, like a cow or a pig for that matter. All right, so now here's our situation. We have a definite case of RDS, and we want to think about treatment. And we want to think about this early. Sometimes you may have to start your surfactant therapy right there in the delivery room before you even get the baby admitted to the nursery. So then we have sometimes what's called like, we might just do it prophylactically because we know this is a very small baby who's at really high risk of developing RDS, or it may have to be an actual rescue dosage where, like I was saying, you may have to do it right there in the delivery room. Now, it says here currently 5, but this book, of course, was published a little while ago. And I had to update at least this right here, like they still had Exosurf, but this has been DC'd. I mean, you're not going to find this in the formulary anymore. But these are just some of the other options that you have, like Surfactant, Survanta, Curosurf, and Infosurf. Now, no matter what you choose, whether you choose Curosurf or Infosurf, Surfactant, it's not guaranteed to work. I mean, you just have to wait and see what happens. And if they don't really respond, then you got to be thinking about there's probably a problem. There's probably an issue with the surfactants proteins. So like that SPB protein, for instance, that's something they have to look very carefully into and say, let's check to see if we have enough SPB proteins in this surfactant. Or it could be something going on with the AC membrane. And that could be one of the reasons why the surfactant is not being absorbed like it's supposed to. Or it could be another, like an alpha-1 antitrypsin issue that is causing the surfactant really not to work like it's supposed to. But either way, this is how it would usually happen. Let's say the baby's been born and the baby was very, very premature and he's on the ventilator. Now, with neonates, pressure control is usually where you start. So unlike the adults, where we always try to start at volume control and then go to pressure control if we have to, with babies, you're just pretty much going to start at volume control because there's really no tidal volume that you can try to target for them. They're just too small. So you'll just, you'll have them in pressure control. And with pressure control, you cannot predict what kind of volumes you're going to get. You just have to wait and see. But this little one is not doing well. He's not oxygenating very well. And just overall, he's not doing that great. And we know it's because of the surfactant issue. So then we give our surfactant therapy, no matter which one we chose, we give that first round of therapy, and then we have to stand by and watch very carefully to see what happens. Because if surfactant will work, it will usually start working pretty quickly, meaning that, let's say you were starting off in a pressure control of 24. And then you looked at the average volumes that were being delivered to the baby was maybe like about, maybe about 10 cc's. And then you give the surfactant and then you wait and watch to see what happens. Within a few minutes, you may notice that that volume goes from 10 cc's to like maybe, it may jump to like 50 cc's. And that means that you've got to be quick to change your pressure setting. So you've got to turn your pressure control setting down to prevent barotrauma. But then if the surfactant really isn't working, then you're not going to possibly see that kind of a change or that kind of a major improvement in the overall volumes that the baby ends up getting. So you can't, in other words, you just can't give the surfactant and then walk away, because there's always a safety concern that surfactant may start working very rapidly, and those lungs may start to rapidly respond by inflating much easier now. Okay, now this video here is how most hospitals are going to do their surfactant replacement therapy. And you don't have to be already intubated to get surfactant. and you don't have to worry about a lot of the other details. But they did a pretty good job, I think, in this video. So they're going to use CuraSurf and show you how that works. And if you hear them use the word aliquot, aliquot just means that you took the dosage and you divide it up into like equal dosages. So you're like giving like, maybe like you got 3 aliquots and you give them one at a time. Now, let's find the video here. Now, similar to the last video, this is kind of like a commercial, which means that I'm not going to play everything.
In recent years, the neonatal community has experienced a rise in the use of non-invasive ventilation methods for the initial resuscitation of premature infants diagnosed with respiratory distress syndrome, or RDS. While non-invasive ventilation methods may help to protect the premature lung from the potentially harmful effects of more invasive therapies, clinical trials suggest that approximately 50% of non-invasive ventilation methods fail. The American Academy of Pediatrics guidelines strongly recommend the use of the Early Rescue Ensure technique if nasal CPAP has failed. Ensure is an acronym that stands for intubation, surfactant, and rapid extubation. This technique provides the benefits of surfactant while avoiding prolonged mechanical ventilation. In clinical studies evaluating the Ensure strategy with CuraSurf, infants have been able to be extubated within approximately 5 to 10 minutes after surfactant is administered. Extubation time may vary significantly based on the clinical scenario and should be performed when the infant is stable at the discretion of the clinician. When considering if the Ensure technique is appropriate for a specific infant, it is helpful to evaluate factors such as birth weight, gestational age, respiratory requirements, and prenatal care. Administration of a single dose of surfactant via the Ensure technique seems to have the greatest success in infants with body weight greater than 750 grams, less severe RDS, and those who may have benefited from a course of antenatal corticosteroids prior to birth. In addition, studies have shown that timing of the intervention may impact outcomes. It is recommended to intervene before the infant's FiO2 reaches 45%. The following is a step-by-step demonstration for administering a rescue dose of CuraSurf in conjunction with the Ensure technique. CuraSurf should be dosed and administered in accordance with the full prescribing information. The dosing of CuraSurf is based on birth weight and differs between initial dose and repeat dose. The initial recommended dose of CuraSurf is 2.5 milliliters per kilogram of birth weight, or 200 milligrams per kilogram. If necessary, repeat doses of CuraSurf should be administered at 1.25 milliliters per kilogram of birth weight, or 100 milligrams per kilogram, half the initial dose, at approximately 12-hour intervals. Before administering CuraSurf, assure proper placement and patency of the endotracheal tube. In many centers experienced with the Ensure technique, taping of the ET tube is optional. It is possible to administer CuraSurf intratracheally using 2 methods, either as a single aliquot over 1 minute, or as 2 divided aliquots, using a 5 French end-hole catheter. Choice of administration method will depend on practitioner preference and clinical scenario. During this demonstration, we will focus primarily on the 2 aliquot approach. Please reference our main administration video or the CuroSurf full prescribing information for additional information on the single aliquot method. When administering CuroSurf using a 2-aliquot approach, briefly disconnect the endotracheal tube from the ventilator. Keep the infant in a neutral position and insert the pre-cut 5 French end-hole catheter into the ET tube and listen for equal and bilateral breath sounds. The infant should be positioned so that the right or left side is dependent for the first aliquot. Instill the first aliquot of CuroSurf, 1.25 milliliters per kilogram of birth weight. After the first aliquot is instilled, remove the catheter from the endotracheal tube and manually ventilate the infant for 1 minute. When the infant is stable, reposition the infant such that the other side is dependent and administer the remaining aliquot using the same procedure. After completion of the surfactant dosing procedure, resume usual ventilator management and clinical care. For the purposes of this demonstration, the infant has been rapidly extubated to non-invasive ventilation. In this scenario, it may be helpful to resume non-invasive ventilation prior to extubation so as not to lose functional residual capacity. Once the nasal prongs have been reset in the nares and respiratory support has been established, you can remove the endotracheal tube. Extubation should be performed at your clinical discretion when the infant is stable. In a clinical trial, CuroSurf has been shown to improve oxygenation within 5 minutes when using a conventional mechanical ventilation strategy. Therefore, it is best to remain at the bedside following administration. Infants should receive frequent clinical and laboratory assessments, monitoring oxygen status, airway pressure, and respiratory rate. During this time, it is important to adjust oxygen and ventilator settings as respiratory status improves, or if you detect acute deterioration, cyanosis, or bradycardia. If a repeat dose of CuroSurf is needed, dosing via the Ensure technique may be considered. There are dosing precautions consistent with all surfactants. Transient adverse effects seen with the administration of CuroSurf include bradycardia, hypotension, endotracheal tube blockage, and oxygen desaturation. These events require stopping CuroSurf administration and taking appropriate measures to alleviate the condition. After the patient is stable, dosing may proceed with appropriate monitoring. Here are a few points to keep in mind. The Ensure technique shows greater success in infants with birth weight greater than 750 grams, less severe RDS, and those benefiting from a course of antenatal corticosteroids. Many experienced centers forego taping of the ET tube to allow for rapid extubation. Prior to extubation, it may be helpful to re-establish non-invasive ventilation to ensure maintenance of functional residual capacity. And for any infants who require additional surfactant dose, administration via the Ensure technique may be considered. Indication: CuroSurf Parectin Alpha intratracheal suspension is indicated for the rescue treatment of respiratory distress syndrome, RDS, in premature infants. CuroSurf reduces mortality and pneumothoraces associated with RDS. Important safety information: CuroSurf is intended for intratracheal use only. The administration of exogenous surfactants, including CuroSurf, can rapidly affect oxygenation and lung compliance. Therefore, infants receiving CuroSurf should receive frequent clinical and laboratory assessments so that oxygen and ventilatory support can be modified to respond to respiratory changes. CuroSurf should only be administered by those trained and experienced in the care, resuscitation, and stabilization of preterm infants. Transient adverse reactions associated with administration of CuroSurf include bradycardia, hypotension, endotracheal tube blockage, and oxygen desaturation. These events require stopping Curosurf administration and taking appropriate measures to alleviate the condition. After the patient is stable, dosing may proceed with appropriate monitoring. Pulmonary hemorrhage, a known complication of premature birth and very low birth weight, has been reported with Curosurf. The rates of common complications of prematurity observed in a multi-center single-dose study that enrolled infants 700 to 2,000 grams birth weight with RDS requiring mechanical ventilation and FiO2 greater than or equal to 60% are as follows for Curosurf. 2.5 milliliters per kilogram, 200 milligrams per kilogram, N equals 78, and control N equals 66, no surfactant, respectively. Acquired pneumonia, 17% versus 21%. Acquired septicemia, 14% versus 18%. Bronchopulmonary dysplasia, 18% versus 22%. Intracranial hemorrhage, 51% versus 64%. Patent ductus arteriosus, 60% versus 48%. Pneumothorax, 21% versus 36%. And pulmonary interstitial emphysema, 21% versus 38%. Please see accompanying full prescribing information.
So that's pretty much how every hospital is going to do it. And again, the baby doesn't have to be intubated to receive the surfactant therapy, but they will have to be temporarily intubated. So that way you can get it right into the lungs. And then you could just, as you see, rapidly extubate them and then place them back on CPAP. Now, one thing I wanted to also comment on is, and some of those shots, they were showing people with no gloves touching the babies, like assessing and what have you. But the therapist that actually instilled the Curosurf had on gloves. Now, what that's about, it's not really that big of a deal, because before you go into any nursery, like each day, before anybody walks into the nursery, everybody has to do a surgical scrub. And you got to scrub literally from your fingers all the way up to your elbows, just like you were going to go in and do surgery. You're using the same type of material with a brush. You got to clean underneath your fingernails. You got to scrub in for a good 5 minutes at least, like minimum. And then once you're inside the nursery, you'll still follow, you'll wash hands between patients, and you'll gel in between patients when you need to with alcohol gel. But for the most part, if you're not going to really be coming into contact with like bodily fluids, anything like that, it's no problem if you're going to be doing something with just your bare hands, because you're surgically scrubbed. You're scrubbed in for that day. Now, respiratory distress syndrome. So here's a picture where this infant definitely has the ground glass type of appearance that will usually be associated with respiratory distress syndrome, or like in ours, it kind of shows up the same way. It looks kind of hazy and almost like a glass kind of appearance. And this baby does not appear to be intubated, but it's kind of hard to tell. I can see the feeding tube that goes straight down into the stomach, but I can't tell if there's an ET tube. But again, you don't have to be intubated to receive your surfactant replacement therapy or your exogenous surfactant. This is probably just a baby on CPAP, and they've got the feeding tube in place to ensure that the belly doesn't get too full of air. And then after the surfactant, notice that there is a definite improvement. Now I see a little bit more black where before I couldn't see nothing but white haze, which would, of course, assume you have to assume that there's a lot of infiltrates and atelectasis. But then after just that first dose, you're seeing improvements. And you should also see improvements with oxygenation and with ventilation. And that would mean that you may have to give another dose later, and then you'll probably get even more improvement. So now we can use surfactant for more than just RDS. I mean, there's a lot of other reasons why you should consider some type of replacement therapy. And these are just some of the ones that can be problematic for the baby. And you would have to kind of think about doing something like Curasurf or Infasurf or surfactant or whatever the case may be. Anywhere from the pulmonary hemorrhaging, anything that's going to fill the lungs up with fluid, whether it's blood or interstitial fluid or whatever the case is, it's essentially going to just wash out your surfactant anyway. It's going to essentially deactivate the surfactant. So the pulmonary hemorrhaging, even meconium aspiration syndrome, is going to cause problems with this surfactant. And of course, pneumonia. And they do a lot of this with ECMO babies. ECMO comes up in another chapter later, I think next week. And of course, with ARDS. Now, we've tried surfactant with adult patients at the last place I worked. And we didn't hold out much hope for it. We just figured it was more so it was the pharmacist. The pharmacist wanted to try and see what will happen, because I think the pharmacist was trying to like publish something. But here we were with this adult patient who was on high frequency oscillation. And then we all, as a team, went in and we started doing the surfactant to see what would happen. And it didn't really work at all. That patient's lungs were so bad, they weren't even really absorbing like a fraction of the surfactant that they should have been absorbing. But again, it was all about, let's see what happens. But there's some other things here. And of course, even with some asthmatics, you may have to consider maybe some surfactant replacement and cystic fibrosis. Now, where are we heading? And we're already there, because it's all about just, making sure, like with using the amniotic fluid, for instance, instead of using the surfactant that you got from a cow's lungs or the surfactant that you got from a rabbit's lungs. It's all about just trying to like crack the code, like on the genome, and manufacture your products that are definitely going to be tailored to your genetics, or just to human genetics. All right, so our questions for this chapter here, or these two chapters. This is a multiple. So how many of these would you choose if you wanted to deliver Heliox? What are your options? I see E. Now, E for sure, because we know that E is going to be one, like usually the best bet, but there may be some other options here as well. Think back to that first video where they had the system that was designed to work with the Vapotherm high flow nasal cannula, or the MediPlus. So with your high flow nasal cannula systems, you can integrate Heliox now. And of course, you're not a rebreather. And then there's some ventilators that have a dedicated connection that you can use for your Heliox. How does I know reduce your shunt fraction? By decreasing the pulmonary vascular resistance? Well, we got to be a little bit more specific because we keep saying that I know is a selective vasodilator. There are other vasodilators out there, but I know is the only one that's going to target just the areas where there's good ventilation that's already taken place, good oxygenation, good ventilation. It's going to dilate those areas and bring even more blood to those areas, and it'll leave the bad areas alone. Because the last thing you want to happen with the bad areas of the lung is to bring more blood there, because there's not going to be any gas exchange. You're just going to have a worse shunt. And therefore, your I know is going to just focus on the areas that are not bad. Which one of these would be negatively affected? If you were using a Heliox with a ventilator that didn't have a dedicated Heliox connection port. Possibly A. It should be A, yes, because what is volume? Volume is flow times time. And so that means that flow with Heliox is going to be faster. So then that's going to really throw the machine off, because it's going to think that the flow, let's just say it thinks that the flow is 40 liters per minute, and it's just oxygen that it thinks is going into the system, when really Heliox would be going at, depending on which concentration, 80-20, 70-30, 60-40, that flow would be a whole lot faster. And a faster flow with a certain amount of eye time is going to mean a larger volume. So that just means that without having that little special adapter that's built into the ventilator, you're just not going to be able to manage this ventilator at all, because you're going to have to document these numbers and these values, and you can't document something that's going to be erratic. I mean, maybe one breath it may show that your tidal volume, your exhale tidal volume is, say, like this is a pediatric patient, so your exhale tidal volume is 80 milliliters, and in the next breath it may show that it's nearly 200 milliliters, and it'll just be really, really erratic. And that's why you have to seek out the right machine to get the job done if your goal is to still give Heliox therapy while they're intubated. So what should be done if your surfactant therapy starts to back up into the ET tube? So should we give that aliquot slower? So in other words, you're instilling, or you're adding the surfactant and you're delivering it into the ET tube, and it's just coming back out. It's like backflowing, meaning that it's not really absorbing fast enough. So the best thing to do is you need to stop. You need to stop and give the lungs a chance, maybe to start to start absorbing that surfactant, and then try again. If it starts to go down again, you see it going down the ET tube. Some people will end up taking the bag, the manual resuscitator, and they'll start to try to bag it into the lungs. But I'm here to tell you that's not going to usually work either. It just takes time sometimes, especially when you're dealing with a very small set of lungs to begin with. And then this suction the ET tube, you never really want to do that. In fact, after you deliver your surfactant therapy, you're not supposed to suction for at least an hour or two afterwards, so that way you give that surfactant still a better chance of getting absorbed into the system. Is this true or false? So does the synthetic types of surfactant that they make in the lab, do they have the same SPA, B, C, D proteins as you would expect in the cow's surfactant? Right. It's not possible. There's just no way, because it's synthetic. You know, they engineered this stuff in the lab, and it has pretty much the same type of qualities as your normal surfactant, but it's still synthetic. So it's not going to have all the A, B, C, and D proteins that you'd expect to find in, say, like a real animal. Now, which type of deficiency could it be here? Could it be the alpha-1 antitrypsin, right? And had D said SPB, then it could have been also the reason why the baby's not getting any better, even after you've given all this surfactant therapy. Okay, so that is chapters 18 and 14. Now, again, tomorrow is your hands-on